Welcome to 12 Lead Part 6, Bundle Branch Blocks and Axis Determination. Don't be scared by the title. This section intimidates some people, but it doesn't need to be as complicated as we make it sometimes. Let's start with a quick anatomy review, just talking about the bundle. So we talk about the AV node and the bundle of His, and then below that it breaks into two branches, the left and right bundle branch. The left bundle branch has two fascicles. The anterior, which goes along the front, feeds the front area near the left anterior descending artery. Posterior fascicle wraps around the backside, provides that stimulation to the muscles on the backside of the ventricle. The blood supplied to the posterior fascicle is supplied by the left circumflex and also the right coronary artery. Good to keep that in mind when we look at different bundle branches or different hemiblocks, which I'll talk about in a minute, that may be affecting just part of that left bundle branch. And then the right bundle branch is just a single structure that branches into much smaller but not specifically identified structures. When we talk about a bundle branch block, that label means that we're describing something that blocks the entire left bundle or the entire right bundle branch block. When you hear the term hemiblock, or also called a fascicular block, that means we're just talking about a blockage of the left branch and specifically downstream from that bifurcation. So we're talking about a block of the posterior or a block of the anterior, or theoretically you could have blockages in both. A left bundle branch block might be a pre-existing condition in any patient that you're seeing, but it also can be caused by acute coronary syndromes. We talk about bundle branch blocks as being an alarming finding if it's new, because a likely cause is an acute myocardial infarction. And if it is being caused by an MI, then there is about a 60 to 70% chance that you're going to develop pump failure. That blockage of the left bundle branch takes out so much of the coordination of the left ventricle, it's not able to pump forward efficiently, meaning fluid's going to back up into the lungs. In those patients, the mortality rate, if they don't get reperfusion, is in the 40 to 60% range. So this is a significant finding, a significant problem. Again, if we know it's a new onset of a bundle branch block, that can be an ominous finding. When we think about bundle branch blocks in the context of 12-lead interpretation, it can be challenging because it's critical to reperfuse these patients for the reasons I just mentioned, but it's also hard to identify a STEMI when a bundle branch block is present. It's not impossible, but it makes it more challenging. A bundle branch block can mimic the evidence needed to identify an MI. It also can hide the evidence we need to identify an MI. When we think about it, a bundle branch block by its nature is going to make a wide QRS, which often can result in ST elevation, ST depression, tall or odd looking T waves. All these things can happen as a result of that morphology, that electrical movement. Because the electricity has to go around the blockage, the depolarization takes a wide, slow, funky kind of route, which often will result in odd, funky looking ST and T waves. All of those parameters can also hide all of that. So the patient who you would normally be able to see ST elevation or depression, you may not be able to identify it because of the shape of the QRS in the presence of a bundle branch block. Makes it odd and difficult to identify some of these parameters. So a lot of people notice the bundle branch block quickly because of rabbit ears or about a little notch in the QRS. And that's a good clue. It's a great clue. But it's really not about that. And actually, bundle branch block interpretation is really, really simple. The only criteria you need to have is you need to be convinced that this rhythm is supraventricular, meaning it originates above the ventricles. That could be sinus, it could be atrial, but we believe it's coming from above the ventricles and it's producing a wide QRS. Now, wide in this case might be identified as either greater than 0.12 or perhaps just greater than 0.10, which is confusing because technically we say that up to 0.12 is a normal narrow QRS. So if it's 0.10 or between 0.10 and 0.12 and has a strange shape, a strange morphology, has the notch, that's going to make you realize that this is probably a bundle branch block. So here's some examples. So when we look at these rhythms, for example, you can see that we've got P waves in front of each one of these complexes. We can identify the bundle branch block or the presence of a bundle branch block in any lead. Oftentimes your V leads are going to be your best place to spot them, but not always. And what we see is that there is a P wave in front of this complex and we have a wide QRS. Once we've determined that we think there's a bundle branch block, we look at V1 specifically to determine whether this is a right or a left bundle branch block. And this is a really important point to remember, because if you look at one of the other leads, lead 2, someplace else on your rhythm, you're going to get it backwards. So we look anywhere on the strip to decide that it is a bundle branch block. We look at V1 to determine if it's a left or a right bundle branch block. The way we make that determination is we need to pay attention to the shape of the QRS, and what we really care about is the terminal velocity, the terminal deflection, which means the last direction it pointed. So we find that J point, and the example on the left is a positive deflection. The example on the on the right is a negative deflection. So that is our terminal force in lead V1. So now that we've decided this is a bundle branch block, now that we're looking at V1, I've determined the terminal force. What is the last direction that QRS was pointing before it went back to the J point, to the ST segment? And if it's going up, that's a right bundle branch block. If it's going down, that's a left bundle branch block. One way to remember this is picture yourself driving a car. You're holding the steering wheel, and this little triangle, this little pointer on the screen right now is telling you which way to move your turn signal. If you're pushing your turn signal up, that's because you're taking a right turn. So that image on the left is a right bundle branch block. If on the other hand, you follow the directions there, you push your turn signal down, that's a left bundle branch block. Another way to think of it is picture yourself driving backwards along that baseline towards the QRS complex in your little ambulance. When you hit the J point, which direction are you turning? If you're turning right, it's a right bundle branch block. If your ambulance is turning left, it's a left bundle branch block. So here's an example. We've got a P wave, we've got a QRS, and obviously this is a left bundle branch block. Here's another example. We've got a biphasic QRS. That terminal direction is up. That means this is a right bundle branch block. And again, we're always looking at V1 to make that determination. Another example, a right bundle branch block, and a final example of a left bundle branch block. Hemi blocks get a little more confusing and a little more subtle in their appearance. And essentially what we're talking about is a blockage of one of these fascicles further down, not the main proximal portion of the bundle branch. And an anterior fascicle is more common than a posterior. It can impact function of the left ventricle significantly. Where it shows up in our 12 lead is in a pathologic left axis deviation. And I'll talk later about how you determine axis deviation. But we know that a posterior is going to show up differently than an anterior, and that anterior fascicle is going to cause a pathologic left axis deviation. This may occur in the presence of a right bundle branch block or a normal QRS. So it may be that you see what looks like a normal narrow QRS in a complex, but the axis deviation is what clues you into the fact that they have some amount of blockage of one of those fascicles. The posterior fascicle, as I said, is typically an indication of a greater problem, a more significant cardiac disease, but it's also less common. This supplies the impulse to the majority of the inferior wall of the left ventricle, which kind of makes sense because it's supplied by that circumflex and right coronary artery, which also supply the inferior wall of the ventricle. And if it blocked, it's going to show up as a right axis deviation. Again, we'll come back to axis deviation in a minute. Usually, a right bundle branch block is also going to be present, but again, you might have a normal looking QRS, and the only clue of this posterior blockage is the fact that there's an axis deviation. So why does it matter? Primarily, we use this to identify patients that are high risk for a complete heart block. Hemi blocks, bundle branch blocks, and AV nodal blocks are all precursors to a complete heart block. It's good to think of these as clues that you have a messed up conduction system. The more blockages you have along the conduction pathway, the more likely this patient is to progress on to a complete heart block, which can be a life-threatening event. We need to be ready to pace these patients. So if we pick up on these clues early, we can be ahead of the curve in terms of recognizing which patients might develop a complete heart block and which patients might need a pacemaker. So what leads to a complete heart block? Any type 2 AV block, type 2, a second degree type 2 is a good clue that there's erratic and inconsistent conduction through the AV node. It's just a short distance away from a complete blockage. Anybody with 2 or more of any of the blocks. For example, if you see a prolonged PR, we usually classify that as a first degree block, and we don't attach much clinical significance to it. But if you have a prolonged PR interval, meaning there's a delay in the AV node, and you also have a hemiblock, one of these other axis deviations, telling you that there's blockages down further in the conduction pathway, that combination increases the risk. The patient who has both a right bundle branch block and an anterior hemiblock or a posterior hemiblock, any combination of more than one blockage is a clue of a conduction system that's at risk. So I mentioned axis determination, and that we see that right or left pathological axis deviation is our clue. When I went to paramedic school 100 years ago, this was really tricky to determine. We had a whole complicated formula that you had to look at multiple leads and measure different things. It's much, much simpler now because the machine is going to do it for you. I want to explain what the axis determination represents so that you have a good understanding of it. The axis is simply the mean vector, the overall general direction of electrical impulses as they travel through the heart. So our electrodes at the surface measure electricity moving in a variety of directions, and the axis is if you sum those, add them, subtract them, take the net result of all the electrical movement, what general direction is it all moving? It's going to give us a good idea, and normally, in a normal healthy heart, it should generally go from the upper right to the lower left. It's going from the SA node down to the ventricles. That's the direction the predominant electrical flow occurs. So to determine axis, what you need is a 12 lead, and you need to have the leads correctly placed on the patient. This is one of those times when having the limb leads on the limbs is critical. Putting your limb leads on the torso, especially in close on the torso and away from the extremities, will significantly change the machine's interpretation of axis and not give you accurate information. You need to have a basic knowledge of what the axis deviation represents. So here's a great little diagram that sort of shows, if you look at the top left of this picture, is representing the patient's right shoulder, essentially, and we know that most electricity in most patients is going to move from that right shoulder to that left leg, which is what puts it in that normal QRS axis. So anywhere from -30 to 90 is considered normal. So obviously in some patients, the electricity is almost going from right to left horizontally rather than in a downward direction, and that's okay. That's still a normal physiologic variation. If we get an axis deviation that is -30 to -90, shown in green here, that's considered a left axis deviation. That would be a pathologic axis deviation. It's moving in the wrong direction as indication of a blockage that we discussed earlier. Similarly, what's shown in blue is the right axis deviation. So that is a 90 to 180. That is also showing electricity is moving in a significantly different direction than is normal in a healthy conduction pattern. And the last example shown here, kind of labeled no man's land, extreme axis deviation, this is showing you that the majority of the electricity in this patient's heart is moving from the bottom left to the top right, which is typically going to be associated with a ventricular rhythm, a ventricular tachycardia, or incorrect lead placement. If you have a healthy, normal-looking patient and you have extreme axis deviation, it's likely that you actually have your leads hooked up incorrectly. So your best tool for axis determination is your monitor. All of our monitors will give us an axis measurement. So in this case, we have a PRT axes here, 78, 61, 53. So the one we really care about most is that R axis. In other words, the QRS, the predominant movement. Now, if you're a cardiologist, well, first of all, if you're a cardiologist, you're not watching this video to learn about 12-lead interpretation, but you may be able to gather some significance by the atrial axis as well as the repolarization axis, gets into subtle clues, pick up on things like atrial enlargement and things that I don't care about as a paramedic in the field. What I do care about is that primary QRS axis, 61 degrees, tells me that this patient has a normal axis. Why it matters, or why we're supposed to pay attention to this in our 12-lead interpretation, is because of the thing I mentioned earlier, which is that identification of hemiblocks. If we notice that there is a significant axis deviation and they have any other blockage present, then there's potential for a complete block. There's suggestion that it could be an MI, even if we don't yet have STEMI evidence of that. And it can clue into some other cardiac pathologies, some other cardiac disease that might be present. It can help us to differentiate between SVT and VTach. So in another video I have on ACLS and managing tachycardias, I talk about SVT with a wide complex. Well, any patient with a bundle branch block who's tachycardic ends up with a wide complex tachycardia, and it can look a lot like VTach. If you look at your axis and your axis is going top to bottom, right to left like it should, then that's most likely SVT, even if it has a wide appearance. If, on the other hand, it's wide and fast and most of the electricity is traveling from the bottom left to the top right in the patient's heart, then that's most likely VTach. So here's an example of a right bundle branch block. You can see we have a sinus beat. We have a P wave in front of every complex across this rhythm. We have in V1, which is where we make our determination, I can look and see that there is a right bundle branch block. This patient in our printout tells us this patient has an axis of negative 36. So that is a left axis deviation. So that's outside of the norm. It's a pathological clue. And it indicates that this patient has the right bundle branch block that we just saw and a left anterior fascicular block, which is exactly an example of a patient who could be at risk for a complete block. Now, in the context of chest pain, syncope, if this patient looks and sounds, the story fits that they're having an MI, they probably are, and they are at high risk of this progressing on to something worse. So wide complex tachycardia, as I mentioned this before, we can struggle sometimes to identify if it's VTach or it's SVT with a conduction delay. Is it atrial fib, atrial flutter with a conduction delay? So there's some clues we can look at to determine or to quickly decide if we think this is ventricular tachycardia or something else. So the things that favor VTach, I already mentioned that extreme axis deviation. If most of the electricity is going towards the patient's right shoulder, it's probably coming from the ventricles. If the QRS is greater than 0.14, we define a wide QRS as anything over 0.12, but 0.14 is really wide, more likely that that's coming from the ventricle. An AV dissociation, in other words, if you can see P waves, but they're not connected in any way to the ventricular beats, that's a great clue. And suggestive QRS morphology. I love this label. This is a textbook description that basically means it looks like VTach. If you want to believe that it's VTach, you should look for the things that look like VTach. And it does have some characteristic views to it that becomes more recognizable the longer you look at these things. The other is concordance across all the V leads. So if most or all of your V leads are all showing positive or negative deflections, that's a clue of a ventricular originating beat. So in this example of VTach, you can see a few of the things that I'm mentioning. First of all is that AVR is predominantly positive, which is not what we expect to see in a normal healthy rhythm. Another is that concordance that I talked about. V1 here is positive, but V2, V3, V4, V5, and V6 are all negative deflection, which just helps to confirm that this is absolutely VTach. In part 7, we're going to talk about imposters, STEMI imposters, and how to identify them.